Welcome to Dr. Balga's podcast for the Curious Doc. Today is April 2nd, 2026. This video is on a New England Journal of Medicine article published 3 days ago on March 30th, 2026. It's titled Discontinuation of Beta Blocker Therapy After Myocardial Infarction by the Smart Decision investigators. The study question: after at least 1 year post myocardial infarction, can beta blockers be safely stopped in stable patients without heart failure? The rationale: benefit is clear with reduced left ventricular ejection fraction for beta blockers, but uncertain in modern revascularized survivors with preserved LV function. Methods: open label randomized non-inferiority trial at 25 centers in South Korea. The study cohort comprised of 2,540 individuals. Beta blocker discontinuation in approximately half, 1,246, versus continuation in 1,294. The mean age of the cohort was 63.2 years. 12.8% were women. 56.8% had a STEMI. 98% underwent revascularization. Eligibility: event-free, left ventricular ejection fraction at least 40%, no heart failure, on beta blockers for at least 1 year, median 4.7 years from infarction to randomization. What was the primary endpoint? Death, recurrent myocardial infarction, or hospitalization for heart failure. The non-inferiority margin hazard ratio is 1.4. Median follow-up was 3.1 years. What did they find? The primary endpoint at 4 years was 7.2% with discontinuation versus 9% with continuation. Hazard ratio of 0.80, p-value 0.001 for non-inferiority. All-cause mortality 2.4% in the discontinued arm versus 3.4% with continuation. Recurrent myocardial infarction 2.3% versus 2.6%. Hospitalization for heart failure 2.2% versus 2.1%. Serious adverse events were also similar, 11.5% versus 13.4%. Per protocol and subgroup analyses were consistent. Key limitations of the study: open label design. All participants were enrolled in South Korea. Event rates were lower than expected, and the non-inferiority margin was relatively wide. Women and patients with mildly reduced left ventricular ejection fraction were underrepresented. What's the key takeaway? In carefully selected late post-myocardial infarction survivors without heart failure, stopping long-term beta blockers was non-inferior to continuing them. Clinical pearls: this trial addresses deprescribing, not whether beta blockers should be started immediately after myocardial infarction. Applicability is narrow: stable patients, no heart failure, left ventricular ejection fraction at least 40%, and already treated for at least 1 year. Median time to randomization was 4.7 years. So the evidence speaks to very late post-myocardial infarction care. The reassuring signal: no excess in mortality, recurrent myocardial infarction, or heart failure hospitalization with discontinuation. Bedside implication: review the original indication. If beta blocker use persists only by habit, this trial supports a thoughtful stop in selected patients. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.